Welcome to Striving for Consensus, optimizing the use of molecular residual disease analyses in the management of colorectal cancer. This is medical oncologist Dr. Neil Love. Joining me for this think tank are Dr. Stacey A Cohen from the University of Washington in Seattle, Washington, Dr. Arvind Dasari from the MD Anderson Cancer Center in Houston, Texas, and Dr. Christopher Lieu from the University of Colorado Cancer Center in Aurora, Colorado, to discuss circulating tumor DNA, ctDNA assessment in the management of colorectal cancer. To begin, I asked Dr. Cohen to discuss the biologic principles underlying ctDNA and molecular residual disease testing in colorectal cancer.
Well, thank you for including me today, and I'm super excited to talk about ctDNA or circulating tumor DNA with this lovely group of people. And so I'm going to kick us off by talking about really what is ctDNA, what are some of the observational studies that we have done, and really why has that set us up for success with future prospective trials. So first of all, what is ctDNA? So when we think about ctDNA, it's a biomarker, but taking a step back, we all have cell-free DNA or cfDNA that is just the byproduct of cellular breakdown that can be detected in plasma and other body fluids. And so the concept is that you take the portion of that is specific to the cancer, and that's what ctDNA is. So you're looking for differences in genetic changes, epigenetic changes, fragments, et cetera. And the reason why this is maybe potentially an even better biomarker than what we've traditionally used is that the half-life is quite short. So we're really getting a dynamic sort of appreciation of what is going on with the cancer at that time. And we can look at this over time. And so we can think about ctDNA in terms of cancer screening in the first place. We can use it for profiling. We'll focus a lot on kind of this middle time point of looking for residual disease, or the idea of looking for cancer when you don't think that there's otherwise any sign. And then we can look at it more in the metastatic setting for response. And I want to highlight sort of two different ways that we'll look at ctDNA. One is tumor-informed and one is tumor-agnostic. So in tumor-informed, you're actually taking a piece of that individual patient's tumor tissue, looking for specific mutations in that tissue, and then looking for those same mutations in the blood. And so that's a really great process because you're getting an individualized assay. The problem is that takes time. And time would be on the order of a few weeks, especially to do all of that tumor testing. On the other hand, we could do a tumor-agnostic approach, also called tissue-free. And that would be looking at just common mutations in the blood without any individualized sort of characterization of that assay. And that's great because that has a faster turnaround time on the order of usually 7 to 14 days. And so when you're thinking about actually applying the technology, at this point, probably tumor-informed is more sensitive. But on the other hand, tissue-free or tumor-uninformed or tumor-agnostic, however you want to call it, those are going to be with a faster turnaround time, which is something that both have relevance to clinical practice. And so as we think about sensitivity, we also can understand that tumor burden matters. So when you have a larger tumor, you're more likely to be able to tell if there is ctDNA or actually be able to detect it. And similarly, as that tumor volume may grow over time, you're going to be able to pick that up faster when you have a higher burden of cancer, and also can look at things like rate of increase and doubling time. So we can use ctDNA as a single assay, but we can also do longitudinal testing to try and overcome some of our issues with assay sensitivity. So again, the main concept that I think we're going to talk about a lot today is MRD, which is minimal residual disease or molecular residual disease, or this idea that we're picking up small volume disease not appreciated radiographically or with our other measures. And the hypothesis here is that ctDNA can pick up recurrences faster than we would discover with those other measures. And so I'm going to go over some of the retrospective and observational data and then hand it off to my colleagues to talk about the prospective data. But again, I want you to know that ctDNA it's not static, it is a technology. And so we have many areas of potential growth. So originally we might look at just a discrete number of variants. They started with 2. Many assays will check 16, but we can look at bigger panel sizes. We can go from whole exome to whole genome, looking at for, maybe more characteristic variants, adding in epigenetics, which is especially helpful for those tumor agnostic assays, looking at how we cancel out that background noise, that idea of CHIP or other areas of cfDNA that is confusing the picture. And then, there's quantitation. So we can report out positive and negative, but we can also trend it quantitatively and eventually maybe look at fold differences as a biomarker. And so as we've looked at this as a prognostic marker, ctDNA is a very strong prognostic risk factor. And so these are Kaplan-Meier curves done from two different observational studies. On the left, we have a tumor-informed assay. On the right, we have a tumor uninformed or tissue-free assay. And in both cases, you can see that ctDNA negativity had much better recurrence-free survival after surgery as compared to patients who were ctDNA positive. And so these are really separating curves in a way that we hadn't seen in other situations. And so leaning on Dr. Dasari and some of the work that his group has done, we can think about this as a predictor for metastasis. So in the INTERCEPT study done at MD Anderson of over 1,000 patients who were evaluated after surgery, they noted that often when patients came back as ctDNA positive, their providers would order subsequent testing, typically CT, MRI, or PET scan. And from there, about half of patients were found to have radiographic disease. The other half were found to be biochemically positive or MRD positive without any sign of cancer on scans. And so looking at the lead time, while the lead time from ctDNA positivity to radiographic positivity was about 3 months, when you took out that half of patients that did not have any evidence of disease at that time, the lead time was about 5.5 months. And so this is really helpful because this real-time data is helping us understand how do we actually counsel patients. Because as you'll see, we don't have all of the answers for how to use ctDNA. So some of what we need to do is learning how to manage expectations. So to summarize this part of what I'm going to talk about, ctDNA is an emerging technology. It can be very useful as a liquid biopsy. You just have to understand the limitations and the specific platform. We're going to be able to detect it more likely the more cancer there is. So we say it's tumor burden dependent. We think in general at this moment, tumor-informed panels are likely more sensitive for MRD, though that may be changing as technology evolves. And then ctDNA status, of course, has been shown to be highly prognostic. But now, really where it matters is, what about ctDNA as a predictive biomarker? Because it really doesn't help for us to understand that patient's not going to do well unless we can intervene. So I'm going to go over some of the retrospective data and observational data that we have, and then, as I said, hand off to my colleagues to talk about how this has been put forward into clinical trials. So one such example is the part of the Circulate Japan study. They have the Galaxy sub-study, where they took many thousands of patients who had maybe had neoadjuvant therapy but underwent curative intent resection, and then they followed them for 2 years with serial ctDNA testing. And as you can see, there were some opportunities for actual clinical trials based on those results, but I want to just talk about the Galaxy part, which is just the observational component. Sort of concurrent to this, in the United States, we had the Bespoke study, and this was, again, an observational study with over 1,000 patients where they did serial ctDNA testing for 2 years and then also some quality of life assays or questionnaires. And so looking at the Galaxy data, we can learn a lot about sort of what was the observed experience for patients when they were found to be ctDNA positive or ctDNA negative. And you can see here that the vast majority of patients in the green bar were ctDNA negative, and a portion were positive in the MRD window. And there was a little bit of conversion that we would see over time. So notably, patients who went from positive to negative, we may think those could be patients who benefited from adjuvant chemotherapy. Patients who went from negative to positive, there were some folks that had transient clearance. So they briefly became negative and then they went back to being positive. And then we noted that there was about a 5% recurrence risk for patients who were ctDNA negative, where there was a much higher recurrence risk for patients who were positive. And I will note that many folks ask, well, are patients, is this a real biomarker, or do patients ever clear this on their own? They did note about 1% to 2% of patients who did spontaneously clear from positive to negative without chemotherapy, but it's thought of as being a very rare event. So as we think about what is the actual impact of our intervention, we can look at folks who are normally advised to get chemotherapy. So that would be stage 3 and high risk stage 2. And they looked at the role of chemotherapy and whether they were positive or negative. So on the left, you have patients who are ctDNA positive, and you can see that the individuals who received adjuvant chemotherapy in blue did much better in terms of disease-free survival than the patients who were red, who did not get chemotherapy, suggesting that maybe that is where we could see the benefit of chemotherapy. Whereas on the right, we have patients who are ctDNA negative. You can see that those individuals do better overall, and yet there's not really a major difference between the use of chemotherapy or not. Similarly, we can look over time. So those last graphs were by a single MRD time point. But now as we look for longitudinal testing, we can note from the Galaxy study on the left and the Bespoke study on the right that patients who are negative and stay negative seem to do the best. Folks who are positive and stay positive do the worst. And then those who have transient clearance have somewhat better survival, though recurrence is still very common. And so as we follow patients through on these studies, we can think about, how do patients do? Is there the opportunity for actual intervening and maybe resecting? Could we find the area of metastasis and actually take it out? And we'll note that when we look at individuals who are positive versus negative and where they recur, we can note that there are certain high shedding sites like the liver, and there's certain lower shedding sites like the lung and the peritoneum. So it helps us understand that when we get a positive or we get a negative, we may be able to associate that with certain areas of potential metastatic spread. But even when you look among recurrences, ctDNA can still be prognostic, and this may be related to tumor burden. So as we, again, look through the Galaxy study, the patients who are negative did better than patients who are positive, even among those that recurred, maybe suggesting that they were more likely to be resected or had more limited or slower growing disease. And as we look for patients in stage 4 who got neoadjuvant chemotherapy and who were MRD positive, we may see that having had preoperative chemotherapy on the left, the benefit of adjuvant chemotherapy was not as profound as patients on the right who had no prior chemotherapy. So again, this is all fact generating, but suggesting that we may be able to make some treatment paradigms and use ctDNA to design who should actually be receiving chemotherapy and when. And I'll show the flip side here, which is that patients who are MRD negative, really you were not seeing much benefit from adjuvant chemotherapy, just a little bit, whether you were negative or positive. So as we think about the future, our goal is that we can really individualize treatment. Our goal is to escalate therapy for patients who are needed, who we think are the ctDNA positive individuals. We want to de-escalate for patients who are negative, who might not benefit. And we want to look over time to figure out how can we best adapt chemotherapy treatment plans and surveillance strategies. So to summarize, as we turn ctDNA into standard practice, we have good observational studies demonstrating ctDNA is prognostic. It suggests that it's predictive. But I turn to my colleagues to say we need to prove that treating based on ctDNA status plus our standard clinical features, not a replacement, will lead to better outcomes. So we need to better select patients, we need to tailor our regimens appropriately, and think about maybe earlier exposures to targeted therapy. So handing it off to both of you.
So thanks so much, Stacey. I'll start out with Arvind. Any thoughts about the content that Stacey just reviewed? And also curious about your thoughts in terms of where we're heading in terms of tumor-informed or not tumor-informed, whether and how that's going to roll out over the next few years.
Yeah, that is a great talk, really summarizing where we are in the field and also the challenges. Rephrasing and paraphrasing what Dr. Cohen went over. So we have analytical validation. So we have really robust, reliable assays. We have clinical validation in that we can use these assays to really figure out the outcomes for patients in terms of their prognosis. And outcomes with treatment. But what we don't know, what we don't have currently is the kind of the prospective data to have the clinical utility. So are we ready to use these data in clinic today, I think that's the piece that is missing, and that's where the prospective studies are required to really establish that. With regards to the assays, I couldn't have said it better. These assays are technology, much like the large language models that we have or anything else. They're improving very quickly and rapidly. So I think what's true today may not be true in a year. But as of now, I would say that tissue-informed assays so far seem to be more sensitive.
Chris, any thoughts?
Yeah, I think almost the technology has practically outpaced our ability to know what to do with it, right? And I agree with Dr. Cohen and Dr. Dasari. I think this technology is going to continue to evolve and it's going to continue to get better. And I think we're going to be left with some data that's going to be generated using some older assays. I do agree with Dr. Cohen and Dr. Dasari about the use of tumor-informed assay, particularly in the MRD setting. But some of this is also the practicality of waiting 3 to 4 weeks to get a tissue-informed assay test result back. But to go back to the other point, I think that we're going to be left with some prospective data using some older assays, and we're going to need to future-proof some of these studies where we can go back and use some of the newer assays to see if there's a difference in outcomes when the technology continues to improve to allow us to detect disease.
So one final point, Stacey, I was just kind of flashing when NGS came in, and initially I feel like it took 3 or 4 weeks to get NGS, and I don't know currently how quickly they're doing it, but do you see, first of all, how quickly do you get back NGS nowadays, and do you see the possibility that maybe we'll get back these tumor-informed assays or quicker, or do you think that's just the way it's going to be?
I think the feedback that we are constantly giving to the companies is that we need our information as soon as possible, and that makes the assay the most helpful. And I think the problem with tumor-informed assays is the same as NGS, which is the testing companies or platforms can get faster and faster. But the hardest part is physically getting that piece of tissue to the people that need it. And whether you're going from your own hospital or sending it from one hospital to another, that piece is, the companies cannot fuel our pathology departments to work any faster than they already are. And I think that remains one of the biggest bottlenecks.
Yeah, and actually I was thinking about it, though. They not only have to figure out what the mutations are in the tumor, but then they have to do the MRD assay. So it's actually doing more than, I guess, what an NGS assay is. All right, let's move on, and now we're going to start getting into, again, some of the ongoing trials and our attempts to study this. And Chris is going to talk about the potential utility of ctDNA testing in patients with localized disease, localized CRC.
Yeah, thanks. And really just a phenomenal job, Dr. Cohen, in terms of giving us the background and some of the retrospective data. And as you mentioned, we now have some prospective data to look at. So let's see what we have here. So over the next 10 minutes, we're just going to talk a little bit more about the ctDNA testing results, particularly from some of the retrospective studies in regards to the site of recurrence. Going to talk about if there's, what the data is for ctDNA in the neoadjuvant setting. So I'll show you the data, even though it's a little bit scant in that arena. And then we really need to talk about some of the prospective trials that have read out. And we're going to go over some of the de-escalation and escalation trials that have already been reported out. And we'll talk briefly about what trials are coming down the pipeline that will continue to inform what we do in this space. Now, Dr. Cohen showed you just the fact that this is easily the most prognostic test we've ever seen in colorectal cancer. Whenever you see curves like this, and Dr. Cohen did such a great job showing you data from Galaxy and Bespoke, this is a pretty wild separation of the curves showing you how prognostic this test is. And Dr. Cohen also touched on this idea of where the recurrence exists. So this is from the Bespoke study showing that when you have liver metastases, you have a high sensitivity and detection of ctDNA. When you look at lung and peritoneum, that's where these numbers of 76% sensitivity, 79% sensitivity, say for the peritoneum, really start to worry you in terms of making treatment de-escalation decisions based off of this data. And so this is data from the Galaxy study showing you two separate graphs. One is in the MRD window. This is 2 to 12 weeks after surgery, just getting that one time point, and data in terms of site of recurrence anytime after surgery. really kind of looking serially at ctDNA assays. And so there are two take-home messages from this slide, and that is that the rate of finding liver metastases is still fairly high, but there's a miss rate there, and it really gets a lot worse with lung and peritoneum. When you test serially with ctDNA, all these numbers bump up, but we still worry about a pretty significant miss rate for detecting lung metastases and even peritoneal metastases. So, in terms of some take-home points, ctDNA, without question, the most prognostic test that we've seen, but certainly the sensitivity increases with serial testing, and so I think that's an important take-home point. And the liver sensitivity is high, but we do worry about the lung and the peritoneum. I do want to talk briefly about ctDNA in the neoadjuvant setting. So is this something that we can use when we're treating somebody, say, with total neoadjuvant therapy in rectal cancer? And there's a real big gap here in terms of high numbers of patients participating in these trials. And so what we're left with are some retrospective looks of just a handful of patients. And the data here is somewhat conflicting. So when you look at testing ctDNA mid-chemo radiation therapy, you can see that, again, small numbers, but if you're ctDNA negative mid-chemo radiation for rectal cancer, there's a really high prediction for TME-free survival compared to if you're ctDNA positive. This is a study, again, incredibly small numbers that really show that ctDNA doesn't have a ton of specificity or sensitivity in terms of predicting pathologic complete response as well as disease-free survival. So if you're ctDNA negative before treatment or positive, it didn't really seem to show a significant difference in disease-free survival, and even ctDNA before surgery didn't really show any difference. However, in the MSI high space, and this is data from the MD Anderson group looking at pembrolizumab prior to surgery, you can see that those patients that are ctDNA positive that cleared their ctDNA on pembrolizumab, and again, this is for MSI high colorectal cancer, that the pass CR rate prediction here is actually quite good. And if the ctDNA didn't clear or actually went up, you can see that the pass CR rate is certainly not quite as good. And so in terms of the prognostic value in the neoadjuvant space, I think that is high, right? Clearance of ctDNA during neoadjuvant therapy does predict some recurrence-free survival. In terms of predictive value for path CR, I would say it's moderate to low for microsatellite stable colorectal cancer, but the data is actually better for immunotherapy and MSI high colorectal cancer. And right now, I don't think we can necessarily use ctDNA alone to omit surgery, obviously outside of a clinical trial. I want to go over some data for prospective studies that have been done in stage 2 and stage 3 colon cancer. And DYNAMIC is a pragmatic trial done in Australia and in Canada where patients were randomized to receive standard management for stage 2 colon cancer or ctDNA guided management. And if patients were ctDNA positive, they were kind of escalated there to adjuvant chemotherapy. If they're ctDNA negative, they were given observation. And it's a really interesting finding on this study that the patients did equally well, and they did pretty well universally, but both arms actually did equally well. These curves are exactly on top of each other in terms of standard management versus ctDNA guided management. But you just see that there is half the chemotherapy utilized in the ctDNA guided arm. And I think that this data is incredibly strong for stage 2 colon cancer. And I honestly believe, and I know we're going to go over the survey results, but that ctDNA guided management can be and maybe should be considered in low risk stage 2 colon cancer, where we typically do not offer adjuvant chemotherapy. And so my question is always, if your postoperative ctDNA is positive, would you want adjuvant chemotherapy in that setting? And I think based off of the data that Dr. Cohen showed you, that a lot of the time, that answer would be a resounding yes. Well, what about stage 3 colon cancer? And so Dr. Cohen showed you this great figure from Dr. Dasari's review article on ctDNA, and showing that this really represents an area where we need better de-escalation strategies and certainly escalation strategies. And so can we really impact ctDNA positive disease? There have been several trials that have started to look at this question. Now, Altair is part of the Circulate Japan study that Dr. Cohen showed you, but there was an escalation arm for Circulate Japan. And this is in patients that had completed their treatment, whether they got adjuvant therapy or not. And if they're ctDNA positive, they are randomized to receive nothing or TAS 102. And what you see here is that that TAS 102, trifluridine tipiracil, did not improve disease-free survival. Now, whenever you look at curves for disease-free survival, you never want to see them come together, and that's exactly what you're seeing here. So you're not curing people of recurrent colorectal cancer using this agent. The data in stage 4 disease is a little stronger, but again, you see those curves come together. So this was not a positive study, and trifluridine tipiracil or TAS 102 was not able to improve recurrence-free survival in patients that are ctDNA positive. Interestingly, SWOG 80702, CALGB 80702 was a study done looking at 3 versus 6 months of chemotherapy. Those listening to this have probably heard this 3 versus 6 month debate kind of ad nauseum. This is a study that contributed to the IDEA collaboration. But as part of that study, patients were randomized to receive celecoxib after the completion of adjuvant therapy or no celecoxib. And there is no disease-free survival or overall survival benefit with celecoxib. But interestingly, there was a disease-free survival and overall survival benefit with celecoxib in the patients that were ctDNA positive. Now, this is a post hoc analysis done retrospectively, but this is a very, very interesting finding showing a DFS and overall survival benefit with an agent that has incredibly good tolerability. And then finally, the Dynamic 3 study was trying to answer this question of de-escalation or escalation in stage 3 colon cancer. This is a pragmatic study where patients were randomized to receive standard management. Investigators did not know the ctDNA result, or ctDNA-informed management, where they would have escalation to usually the triplet chemotherapy if they're ctDNA positive, or de-escalation, a lot of times just to 5-fluorouracil. And so you can see from this slide that in patients that are ctDNA negative, those patients got significantly less oxaliplatin, 34% versus 88% in the standard management arm. But this was also a negative study. ctDNA de-escalation was not proven to be non-inferior to the standard arm. And so here there's a difference of about 3%, and it was not statistically significant. Interestingly, in the low-risk group, there was actually a non-inferiority signal kind of detected there, but that was not seen in the high-risk group. There was an escalation part to Dynamic 3. Again, here, most of those patients in the escalation arm received triplet chemotherapy with FOLFOXIRI or FOLFIRINOX. And you can see here, numerically, actually, the standard management arm actually did better, but this is not a statistically significant difference. And the ctDNA clearance rates here were basically equal between the standard management arm and those patients, again, majority getting triplet chemotherapy. So this is a lot of data. So what have these studies taught us? You know, for treatment de-escalation, I'm not sure that we're ready for prime time, at least from a randomized clinical controlled setting, particularly for high-risk disease. And we certainly need more data from ongoing randomized clinical control trials. In terms of treatment escalation, I would say right now we may not have the right agents in terms of intensifying chemotherapy, but I will tell you that the data with celecoxib is very intriguing, and I know we're going to talk more about that. And so for patients that are unsure about receiving chemotherapy, can ctDNA help guide decision-making? And this is certainly an area where I think ctDNA has a lot of utility. So I'll wrap up with this. What's coming up? We need more data from some of these prospective clinical trials. This is the Vega phase 3 study looking at low-risk stage 3 disease. Patients are randomized who are ctDNA negative to receive CAPOX versus surveillance. This is the Circulate North America study being run in the United States and Canada. In patients with high-risk stage 2 or stage 3 colon cancer, if they have no ctDNA detected, they are randomized to receive chemotherapy or surveillance with serial ctDNA. If patients turn positive, or if they're ctDNA positive post-surgery, they're randomized to receive standard of care, CAPOX or FOLFOX, or escalation to FOLFIRINOX. And I want to close with this. I want to make sure that everybody's aware of crcmrd.org. This is a really nice repository of all the ctDNA positive studies that are currently enrolling. I'm going to show you an example of one trial of a personalized mRNA cancer vaccine that is enrolling patients that are ctDNA positive post-surgery and are randomized following the completion of adjuvant chemotherapy to receive a personalized mRNA cancer vaccine versus placebo. And so I would say that in this, or observation, I would say these are the trials that we're going to see more and more of in the near future. Thank you, guys.
So thanks so much, Chris. Stacey, any thoughts about anything that Chris presented? I'm really fascinating with this post-adjuvant approach and all the different ways to look at it, including daily lifestyle intervention. I've always found that interesting. I think the celecoxib stuff is super interesting, although I don't know if it's actually being pursued in any ongoing clinical trials. Any general comments or questions, Stacey?
I think that's an excellent overview of what we know so far, and also highlights, how much more there is to learn. I think it also highlights the fact that we really need to hone in our questions. We would love to answer all of the ctDNA questions as quickly as possible, but we need to answer the question first about standard adjuvant therapy. We need to look at failures of adjuvant therapy and see if we should be giving them a different chemotherapy regimen, as was suggested by Dynamic 3, or should we be just following one type of therapy with another? And so I think there's a lot of questions, and the reason why we have not been able to totally leap into standard practice is because so many of these questions remain unanswered.
Arvind, any thoughts about these data? I'm also curious, do you ever give sort of lifestyle or dietary thoughts to your patients, MRD or any patients, in terms of trying to avoid recurrence, or not necessarily?
Yeah, starting with kind of Dr. Lieu's talk, that was a fantastic tour de force overview of everything that's happened in the prospective space and that is going on. So I would look at the ongoing efforts as two buckets. Firstly, taking the available adjuvant therapies and asking the question, can we de-escalate these therapies, and can we escalate by adding on known available drugs to these therapies? For instance, adding on irinotecan to oxaliplatin-based adjuvant therapies. So that's in the postoperative space. Now, for patients who are on surveillance and who turn ctDNA positive, what the retrospective studies have clearly, convincingly shown is that without any therapy, these patients would almost always have a recurrence. So we're in a situation currently where we do these tests, but then tell our patients we don't know what to do. The cancer is going to come back, but we don't know what to do. And I think that's where we really need to develop novel therapies. And that's a really powerful model because given the very high event rate in these patients and also the time to recurrence typically tends to be in the realm of months, perhaps 6 to 9 months, as Dr. Cohen showed. So these trials would be very, very efficient. So you could potentially finish a trial with 200 to 250 patients, as we saw with the Altair trial. So very efficient, very quick to do. And the FDA has actually recognized and acknowledged this as a potential path to new drug approvals. And this is not kind of something out in the future. This has already happened for urothelial cancers. We have the approval of atezolizumab that was done exactly the way the celecoxib evaluation was done, initially retrospective, then validated prospectively in a trial. So really excited about that. With regards to kind of exercise and lifestyle modifications, there was a huge splash at ASCO about how exercise is protective. And the commentary was, if this were a drug, this would be $1 billion drug. So I think based on those data, I certainly would recommend all our patients to be active and get exercise.
So final question back to Chris. Any comments on what's thought about the mechanism of celecoxib or similar agents in terms of the anti-tumor effect? And is that pathway and strategy being looked at in current clinical trials?
Yeah, we don't really know what's going on with celecoxib. There are a lot of hypotheses, certainly about COX-2 inhibition, also prostaglandin E impacts with celecoxib. And I think that there is actually a biological rationale in terms of how celecoxib could actually be impacting inflammation and the gut and even the ability of tumors to form. And so one of the things that we have to determine as a field is, well, now do we need a randomized controlled trial to use celecoxib? And I'm not really sure. You think about like some of the toxicity, sometimes cost of these drugs, and when you think about celecoxib, the cost is certainly much more affordable than some of the agents that we use in oncology, and certainly the tolerability and the safety of the drug is extraordinarily well known. And so I know that we're probably going to get to the real world implications of trying to, determine what to do with this data. But, again, I would ask the question, if you're ctDNA positive and you see this data from 80702 with celecoxib, would you take it? And I think a lot of our patients would honestly say yes. But in terms of exact mechanism of action, again, a lot of focus on COX-2, prostaglandin E, and there are other strategies that are being pursued in that area too.
And also in terms of the FDA, we just did a program a couple of days ago with the myeloma investigator Paul Richardson from Dana-Farber, and the day that I spoke with him, the FDA actually came out and said in myeloma, of course, it's a different type assay completely, but it is an MRD assay. They were now accepting this as a primary endpoint of a clinical trial. And in fact, one of the studies that he's doing on a new drug, that is the primary endpoint, MRD. So we'll see where whether that follows in solid tumors as well. All right, Arvind, let's get into the issue of metastatic disease. We talk with a lot of general medical oncologists about patients they're taking care of. I see a lot of them using cell-free DNA in the metastatic setting. I'm curious about the data that you're going to talk about.
Well, thank you very much. And it's really an honor to be part of this very distinguished panel. And so I'll build on what Dr. Cohen and Dr. Lieu have discussed so far, and you'll see a lot of similar themes echoing again in my talk as well. I'll break it up into 4 different questions. Firstly, starting with the benefits of surveillance with ctDNA-based MRD assays, not just in metastatic patients, but also in stage 2 and stage 3 as well. And then we'll talk about the impact of ctDNA in the management of patients with resectable oligometastatic colorectal cancer. And then the last 2 questions would be around patients with established unresectable metastatic disease and the implications of ctDNA testing with regards to monitoring response in patients who are on, say, cytotoxic therapies, and also patients who are on targeted therapies, especially anti-EGFR therapies, to detect acquired resistance mechanisms. So starting with the implications for surveillance in patients with resected colorectal cancer. So this is a kind of a reanalysis of the observational trials that Dr. Cohen had reviewed in her talk, including the Japanese Galaxy trial and the American Bespoke trial. For this specific analysis, cumulatively, there were about 3,000 patients and over 15,000 time points where the ctDNA assays were drawn during surveillance. CEA data were available from the Galaxy trial, so that's about 1,800 of the 3,000 patients. And the patients had fairly long follow-up of close to 2 to 2.5 years. So what the study was trying to do is to look at the potential for identifying patients with oligometastatic disease. And as a surrogate for detection of oligometastatic disease, what they looked at was metastasis-directed therapy, with the idea being that patients who get metastasis-directed therapy, such as ablation, radiation, resection, these are the patients who actually had oligometastatic disease. And these rates were compared for ctDNA versus CEA according to stages. And these are the data, kind of a busy slide, so I'll walk you through this. On the left side of your screen, you have the MDT, or metastasis-directed therapy, for stage 2 and stage 3 patients. And this is further broken down according to ctDNA detection versus CEA changes. So as you can see, in stage 2 and 3 patients, the MDT rate was 32% for ctDNA positive versus 2% for ctDNA negative. And so really statistically significant. And also significant for CEA, but to a much lesser extent, 12% versus 5%. Now, what's really compelling is when you look at the stage 4 patients, you see that ctDNA still continues to be a really significant marker for detecting oligometastatic disease, or MDT rates, but the significance for CEA is no longer noted in stage 4 patients. And there was a formal statistical analysis done comparing CEA versus ctDNA in both stage 2, 3, as well as stage 4 patients, showing that the ctDNA detection, or MRD detection, is a significantly better predictor of patients receiving metastasis-directed therapy, and by extension, detection of patients with oligometastatic disease as compared to CEA. And as a reminder, as was also reviewed by Dr. Cohen and Dr. Lieu, there is the potential for enrolling patients who are MRD positive or ctDNA positive during surveillance onto clinical trials. Here at MD Anderson, we have a platform of trials that are built into the Intercept program that Dr. Cohen reviewed, and in our practice, we were actually able to enroll about 60% of the patients who are MRD positive onto clinical trials. Now, going back to the study that I talked about, that combined data from Galaxy and Bespoke. So those data that we've reviewed so far, we're actually looking at patients who are ctDNA positive and what's the clinical utility in those patients. But kind of flipping the question and asking, what about patients who are consecutively ctDNA negative? So what is the conditional probability that there would be a recurrence, and what are the implications for surveillance for these patients? What these data showed is that if patients are consistently ctDNA negative for about, say, 18 months from the time of surgery, their risk of recurrence after that is minimal to none, so less than 2% or so. So this kind of then begs the question, in these patients, are we able to stop surveillance at the 18 to 24 month mark instead of the needed 5 years or so? Because every time we do scans, every time we do tests, there are not only costs involved, but also the anxiety and stress that it brings along for patients and their families. These are really compelling data, but I must also caution that these require prospective validation as well. Another thing that we should also keep in mind is that the sensitivity of these assays in being able to detect recurrences are dependent on the site of recurrence. For instance, the sensitivity is very high for tumors or metastatic disease involving the liver as compared to, say, smaller lesions in the lung or the peritoneum. These are data that were recently published looking at the detection rates according to metastatic site across different studies. So another thing to keep in mind as well with regards to where we are currently with these assays and how we can use them in real life. So moving on to the impact of ctDNA in oligometastatic colorectal cancer, these data were reviewed by Dr. Cohen already. And I just want to reiterate that even in stage 4 colorectal cancer patients, ctDNA still continues to be a very, very strongly prognostic factor. This is a subset of about 200 patients or so with stage 4 disease who were underwent resection of liver mets. And you can see that on the panel on the left, patients who are ctDNA positive immediately after surgery have much worse outcomes as compared to patients who are ctDNA negative immediately after surgery. And the same for patients who have finished all curative intent therapy, including adjuvant therapy, and have started surveillance. Their outcomes are much worse if they are ctDNA positive. What was really compelling to me is that even in these patients who are stage 4, who did not receive any neoadjuvant chemotherapy after surgery, the benefit of adjuvant chemotherapy when they are ctDNA negative is somewhat muted. So really compelling data, just kind of, again, underpinning the very strong prognostic and potential predictive implications for MRD testing for these patients. Moving on to the third question of ctDNA testing to monitor for response in patients with metastatic colorectal cancer receiving systemic therapy. So this is kind of really depicts the potential challenges for using ctDNA as a marker for predicting benefit from ongoing therapy. And this is what Dr. Lieu had alluded to as well in patients undergoing neoadjuvant therapy as well. The way we approach taking care of patients today is that patients start systemic therapy. We get a baseline scan, and then we get scans every 8 to 12 weeks subsequently to determine whether the patients are responding or not. At least on clinical trials, the way we determine response is using RECIST criteria, and these are defined based on amount of growth of the tumors that we measure in certain limited dimensions, and we have hard cutoffs. If the tumor has grown by more than 20%, that's progression. If it's decreased by more than 30%, that's response. Across tumor types, across different lines of therapy, these are kind of rigid. So how well does that truly capture what's going on in the patient and the patient's needs and requirements is debatable, but that's what we have. Now, the challenge is, how do we use ctDNA assay to fit into these rigid criteria? I mean, as we've discussed, ctDNA assays are of different kinds and they're evolving over time. And also the way they're reported as a quantitative metric is very variable. So do we look at the variant allele fraction? Do we look at the mean tumor molecules? And how do we define the fold change? Is it mean, median? What do we do? And so these are all the potential challenges that we have with regards to using ctDNA to determine response. And there are a few studies, again, kind of reiterating what Dr. Lieu had shown. Again, the underlying issue here is that even in patients who are on active therapy and their ctDNA goes down to 0, we're still not fully confident that these patients have a complete clinical response. Sometimes, in fact, a small proportion may even have just stable disease or a partial response. So even when ctDNA goes away completely, it's still not an indication that you are sure that the patient has no radiographic disease. This is more relevant for GI cancers, a study done by Dr. Parikh out of MGH. She evaluated ctDNA changes and compared those to changes in tumor markers for patients undergoing systemic therapy for metastatic disease. Again, what the study showed was that even though ctDNA is slightly better in terms of sensitivity and positive predictive value as compared to tumor markers, it's still not reliable enough for us to make determinations without really using imaging or other clinical factors. So really not ready for prime time. But again, as Dr. Lieu mentioned, I think it is helpful in monitoring response to immune checkpoint therapies. For instance, in patients who start immune checkpoint therapies, there is a small proportion who have pseudoprogression. And these patients kind of tracking ctDNA along with the clinical picture, I think would help determine patients who have pseudoprogression versus true progression. And again, on the other side of the spectrum, patients who have a complete response, and you're thinking about stopping therapy, if they've had sustained negative ctDNA, that gives you more confidence in stopping the therapy. And finally, kind of to detect acquired resistance mechanism in clonal evolution. I think this is best evaluated in anti-EGFR therapies, where we know that when patients are treated with anti-EGFR therapies, there are resistance clones that develop over time, and there have been number of these alterations that have been detected that underpin these resistant clones. So how do we overcome these clones? One way to think about it would be maybe to go after these resistance mechanisms, develop drugs against these resistance mechanisms. But the issue is that there's a heterogeneity of these mechanisms. So you could see more, about 4 or 5 or even more different alterations that are distinct and discrete. So to target all of them would be very difficult. The second issue is also that even if we're able to target all of these, a lot of these tend to be subclonal. So how relevant are they in a patient's treatment and prognosis? So another way to do this would be to wait until these resistance mechanisms disappear over time. And so that's by giving treatment holidays from these anti-EGFR therapies. And there have been really robust data that suggests that the T-half of these, the half-life of these resistance mechanisms is around 4 to 5 months. So if you wait long enough, you could re-challenge these patients again. An older study that looked at kind of a pooled analysis of re-challenge with anti-EGFR therapies across multiple smaller studies. And what they showed was that this was indeed feasible with a response rate of about 17% in the refractory setting and a median PFS of 4 months and really compelling overall survival of 13 months. And there have been multiple studies that have validated these findings. This is probably the latest study that I could find. And the reason I put this on here is that because it looked at ctDNA status after patients were on a holiday from anti-EGFR therapy, and then they enrolled patients onto therapies having anti-EGFR therapies. And what they saw was that patients who had RAS and RAF mutations in the ctDNA still detectable had worse outcomes as to compared to those that did not. And the median PFS was about 3.3 months versus less than 2 months, and overall survival of 8 months versus 5 months. So again, really compelling data that you could use ctDNA to detect the disappearance of these alterations and re-challenge patients with these therapies. I'll stop there. Thank you very much.
Thanks so much, Arvind. So just a couple quick follow-up questions. First, Stacey, I don't know if you have any thoughts or questions about what Arvind just presented. Also, I was thinking back to when liquid biopsy came out and there was this issue of what kind of tumors shed. And is it the same with cell-free DNA? And do you see different, I don't know if you use the word shedding or detection of DNA. You talked a little bit about it at different metastatic sites. What about different tumors, breast cancer? We talked about melanoma. Is there a variability in how different cancers deliver DNA to the circulation?
Yeah, I think this was an amazing overview of the complexity that we think about in stage 4. And I think, true to many things for colorectal cancer, early stage localized disease seems to be the most straightforward. And we already spent most of this time explaining why it's so complicated. And so then stage 4 is just that much more longitudinally so. So I think these are great points to bring up that, we can look at MRD, we can look at longitudinal assays, we can look at the specific molecular markers, we can look at decay over time. I think these are all going to be things that make our way into stage 4 treatment over the next decade. I look to, scans being one factor, but not the only factor that we're making key decisions on. And so I think what Dr. Dasari presented is just a really amazing overview of the complexity that we're thinking about.
Chris, anything you want to add to that? And again, what do we know about the determinants of whether you actually can pick up ctDNA?
Yeah, Arvind, just phenomenal review of the data. I think that the melanoma data that you showed is actually what scares me the most, and that is, you have these responses by ctDNA, but then when you look at the radiographic imaging, the correlation sometimes just isn't there. What does it mean when some of our metastatic patients clear their ctDNA while on treatment, and how persistent is that, and what does that mean for their outcomes? I think we're going to learn more and more over time. To go back, by disease, there are certainly going to be certain tumors and diseases that shed, more than others. Colorectal cancer has always been the poster child for this just because of the shed rate. But then again, you've seen data now from all three of our presentations about the site, which is also worrisome regarding, low volume lung metastases and peritoneal metastases. But the one thing that really kind of strikes me, and I think the one thing that I believe people are doing in practice is this slide, looking at rechallenge with anti-EGFR. Many practitioners rechallenge with irinotecan and oxaliplatin. We do that very blindly. We just say, well, you've been off of it for a couple months. We're going to try to give it. This is actually a piece of data that really should help practitioners thinking about rechallenge with anti-EGFR. And I think this data is really compelling, that if you have RAS-RAF wild type, ctDNA testing, that those are the patients that, have a chance of having a response to rechallenge. And so I think, this data in particular is the one that I actually think is very compelling.
Okay, well, let's go on now. I want to talk about this survey we just did of 20 clinical investigators. You can take a look at you three are included there. We did have 3 ex-US people there, so that is a little bit of a consideration. But as you can see, these are a lot of prominent leaders in the field involved in guidelines, et cetera. And as I say, I'd be very curious to know whether you've seen other data similar to what I'm about to show to you, or what you've heard in discussions, ad boards, or whatever. But starting out with a bunch of clinical scenarios. Oh, this one's pretty simple. Stage 2, MMR, microsatellite stable disease in general. Do you use cell-free DNA MRD testing? Out of the 20, 6 say no, 3 say occasionally. And you're going to see this throughout this survey, which is about half of the people seem like they're not too excited about it, and about half are, varies a little bit. So I'll just start with that. Arvind, any thoughts? Did we get asked the wrong people? What's going on?
No, I think it just reflects the ongoing debate in the field. I'm willing to bet that had you done this survey 2 years ago, the commonly and usually or always groups would have been smaller compared to where they are now. So I think it's an evolving area. And as more data come out, I think we'll see more patients become converts.
So, Chris, again, it's just, I understand you want to see data, from a pure clinical point of view that the effective therapy is going to change things. But meanwhile, right now, the way we judge it is we try to estimate risk, and we're really treating based on risk, and I don't see anything better or even equal to MRD. Even nodal status, I don't know that is as predictive. Does this make sense to you? I don't want to criticize people, but I just don't understand it.
This is fascinating. And I agree with Arvind in regards to how this has changed over time, but I do find the generally not and occasionally surprising. And I agree. I think the dynamic data is really compelling. I do wonder if some of the answers that we're seeing here is in relation to high risk stage 2. And I think that there is some concern about if you have a patient with T4N0 disease, would you not offer that patient chemotherapy, whether that patient was ctDNA negative or positive? That's a high risk situation. I think most clinicians would just say, I'm going to give you chemotherapy no matter what. But the question that, that's kind of hidden within this question and survey is really low risk stage 2, where I would say I almost usually or almost always, unless a patient does not want it, get ctDNA in that setting, just for the point that I made previously. If it's positive, I'm giving that patient chemotherapy. But I find these survey results really, really fascinating.
Incidentally, Chris, have you seen any surveys like this? Or
I haven't, and I think that this data is really, really novel. And just to your point, you've asked 20 leaders in the field, and they're incredible. And to see this type of heterogeneity really proves to everybody that this is a very evolving field. And I know we talk about, do we have consensus or not? And it is clear that with this, we definitely do not have consensus.
Well, we're just getting started, because we also, what I was really curious about MSI high too. So we're going to get into that, and we'll get into more about stage 2. Stacey, again, any thoughts? And another thing that I should mention too, that as you know, the three of you took this survey. We also asked for a lot of verbatim comments and explanations and people to explain things. And I'm not presenting that, but I read all that, and a lot of people brought up the issue of patients asking for the assay. Maybe people who generally don't do it, but would do it if a patient asked for it. And also just quite a few people brought up, an increasingly important issue that's always been critical in oncology, which is allowing a patient to be part of the decision-making if they want to be and if they have the ability to understand. And this even going back to Oncotype and breast cancer, which really changed the use of chemotherapy in breast cancer. There's always been this thought of, if the patient's already decided, that's a different story. But anyhow, Stacey, any thoughts about this? Again, I just was really surprised.
Yeah, I think that this really reflects ctDNA as a dynamic marker, both in terms of how we think of it in cancer, but also how people use it. And so, as has already been stated, I think a year ago and a year from now, we might get very different results on this type of survey. I think that, as was described, we need to get a very specific situation. So, yeah, I think the answer to a T3N0 could be different than a T4N0. I think that even if you ask oncologists, would they treat in stage 2 based on lymphovascular invasion alone, you're going to get heterogeneity. And I think that there is a lot of equipoise in stage 2 on how you want to read the data and what do you think would happen. But this is really fascinating to see just how different of an opinion you might get and why many individuals go and get a second or third opinion about their cancer care.
So, yeah, it's interesting. Sure. A patient goes to 4 different docs for this stage 2 disease. They might get some different answers. So, Arvind, for every one of these scenarios, we also flipped it and said, suppose the patient is MSI high. That's now a new issue. Obviously, in the adjuvant setting, the neoadjuvant setting, rectal cancer, et cetera. Chris ran a program at GI ASCO where we talked a lot about this. We had questions from oncologists. Last night, we did a webinar on GYN cancers, and I see they've got a neoadjuvant MSI high trial cooking in endometrial cancer for localized disease. So they're looking over at you guys and taking that cue. But again, when we ask most of these scenarios with MSI high, you kind of see the same mix. The people who use it for MSI stable, generally speaking, you see here very similar answers to what maybe a little bit more people saying no. Arvind, how do you see thinking through the MSI setting in terms of MRD and cell-free DNA?
Yeah, in general, MSI high patients tend to have lower risk of recurrence and, by extension, lower rates of MRD positivity. And these patients tend to have lower chance of being ctDNA positive. In patients, again, I think when we say stage 2, we're losing the granularity of whether it's T3N0 versus T4B, MSI high patient. I think that does kind of factor in as well. With regards to whether we should test or not, I think there is that rare patient who's MSI high but is still ctDNA positive, in which case you may want to give them adjuvant chemotherapy. I would say if it is available and the patient is willing, not unreasonable to do so. The other thing that I also want to point out is how much of this these practice patterns are because of lack of access. For instance, internationally, they may not have access to these assays, and they would not use it in any situation as compared to here in the U.S.
Yeah, we try to ask people to kind of, tell us what they would do based on the science, not so much whether or not they can access it. But still, I think that's a very good point. Another thing that people bring up is the cost of the assay. But on the other hand, and again, we saw this with Oncotype, you have to balance out the number of people who are not going to get chemo in terms of the cost equation. So it's not just the cost of the actual assay. So I also want to show you, and again, we have many more questions. I'm not sure we're going to get to everything here today on specific situations. Stage 2, T4N0, we asked about that, and a number of other. But just to sort of get the broad strokes, again, you see stage 3, still similar, even though you kind of hear that people are not as excited. Our data, it looks the same. If you're a user, you'd use it. If not, you don't. Same thing with MSI high, stage 3. You have people who do, maybe a little bit less than before. In stage 2, MSI high, a number of people said, the risk is, as you just mentioned, Arvind, the risk is so low, I just observe these people no matter what. On the other hand, as you point out, if they do show up with a positive assay, they would get, and the adjuvant trial was chemo plus IO also. And the other question is, does MRD affect whether you're going to give them chemo or not? It's kind of hard not to give them IO if you think they're at any risk, but chemo, and we'll kind of get into that with some of the other scenarios. So again, Arvind went through metastatic disease. We said isolated hepatic met. I hear a lot of general medical oncologists talking about cell-free DNA in this scenario, post-op. They may have had pre-op chemo, but again, you see the same split, whether it's MSI high or not. We said, how about if it's a lung met? Same thing, isolated lung met, sort of pseudo-adjuvant therapy, split half 50-50 roughly between whether they do it or not. Stage, again, lung met with MSI high, even more people say they would use it. Not sure exactly why. Here's another scenario I'm really interested in, and we talked a little bit about some of the data. I don't think there's that much data in localized rectal cancer. But Chris, what about the use of MRD both in MS-stable rectal cancer and as we've been talking about so much in MSI high disease, where you maybe going to give an IO and you look like you think you have a CR, you're not sure, et cetera. So what about MRD testing, Chris, in the rectal cancer setting?
Yeah, I do wonder, looking through even some of the slides that you flipped through, I do wonder how many providers are just ordering it all the time, no matter what, or just never ordering it. And I wonder if that's some of the split. It is wild to see a survey where it really is almost always split 50-50. And again, really just reflects, I think, the state of the field and the state of the state currently. But in regards to rectal cancer, I think that this is a tool that can be used. I'm going to really drive home this point that, we should never really be ordering tests unless it's going to change, management and change what we do. And I think that might be some of the difference that you're seeing between stage 2 and stage 3. We're giving every patient or offering every patient with stage 3 colorectal cancer usually some type of adjuvant therapy, whether they're microsatellite stable or MSI high. This is the same thing in localized, locally advanced rectal cancer, where the question is ctDNA going to change what you're going to do? And I think with locally advanced rectal cancer, the key issue here is the watch and wait after total neoadjuvant therapy. And so the question really is, is this, and I don't think that ctDNA should be used alone in isolation to make a determination whether or not you should take somebody to surgery or not. But if you think about like MSI high rectal cancer, we have been fooled before on MRIs and imaging, and even sometimes with FlexSig, with what's essentially scar tissue, but it looks like a tumor. So in those situations where there could be some debate, and you check a ctDNA and it's positive, that might be the patient that you end up taking to surgery because you think that there is residual disease. If you feel like you have scar tissue and that's all that there is and your ctDNA is negative, it might help you feel a little bit better about watching that patient for a little bit longer and seeing how things go.
So I'm going to keep going, and then we're going to stop at some point and get into the cases and maybe come back to this, but just a couple other things for your thoughts. So this scenario here is a patient who has metastatic disease that's not oligometastatic. And here you see a lot less use of even if it's MSI high. We asked a bunch of general. This is where we get into a lot of the specifics you were asking about. So first, what type of assay? And right now, it looks like, first of all, the Signatera, but, also in general, tumor-informed assays, as you all have been talking about, are preferred by the faculty if it's going to be done. Here's the beginning of some of what you were referring to. So stage 2 high-risk features. Now it's a little bit more split away from it, but you still see a third of the respondents saying they would use it in that situation. I guess that means that they would withhold therapy if the MRD was negative. And again, notice this is a younger patient. We also said stage 2 without high-risk features. And you still see the majority of people saying no, although, again, if you present, Stacey, if you have a patient with low risk, I remember, Chris, when you asked this question of the faculty at that meeting, people took like 10 seconds to think about it before they answered. But Stacey, you have a patient with stage 2 disease, and we just went past it, but stage 2 disease, no high-risk features, but they've got somebody who's drawn the assay or you sent the assay and it's positive. Would you treat?
In stage 2, I would. I would say, I'm biased probably, and I believe in the utility of the assay and what we do know, and that we can't wait on every patient till we have more data. But I do give therapy in that situation. I would say that, sometimes the devil's in the details here. And so what does de-escalation mean? Because for me, that may mean I'm more likely to just do more dose reductions earlier for a patient who has a lot of neuropathy. For someone else, they may think of de-escalation as not giving any therapy. So I think as we interpret this and as we actually apply it to clinical practice, it may be that that if we actually really asked even more specific questions, that would get at where people's comfort level is and isn't. But I think that it's just really interesting to see that there's a lot of controversy, and this really reminds me that ctDNA is not meant to replace standard clinical decision making. I think of it as something that increases confidence in a decision you are intending to make and helps you kind of in that gray zone. And so I think as we get into where the gray zone is, where you're left without other factors, that's where I think the utility is the best.
So a couple other factors that are kind of interesting. This probably the most common question I get from the general medical oncologist is, I've got a 75-year-old patient who doesn't want to get chemotherapy. They have one positive node. Should I get an MRD assay and act on that? So we said age 85, just to sort of push that up a little bit. Stage 3, well, we didn't say one node without high, let's say one positive node. And now you see the majority of people who would, let's see here, would treat based on the MRD assay. Any thoughts in general, Arvind, about the use of these assays in stage 3 disease, and again, the opportunity to at least discuss with the patient, particularly if they have a small number of nodes or one node positive, or if they bring it up to you, the possibility of not having chemotherapy?
Yeah, the way these assays are covered currently for reimbursement is every 3 months, and that's reflected in the responses that we see here. And the hope is that by doing it every 3 months, you're optimizing the sensitivity and also aligning it with, say, whenever the patients are getting standard of care blood draws for CEA and other tests. What we don't know and what we need data on is this truly impacting outcomes, and the clinical utility, and also the cost-effective analysis of doing these more expensive assays so often.
So, Chris, what about the use of these assays in people who don't want to get chemotherapy, or people you're concerned about giving chemotherapy, or people are 85, or 90 years old? And also, what about the use of ctDNA to monitor response to adjuvant therapy? We see a split there.
Yeah, it's, again, really interesting survey results. I think these assays are really helpful because we will always have patients that come in, whether they're young, middle-aged, or older, and they'll tell us, I'm getting chemotherapy no matter what. And then that's a very straightforward conversation. But there are patients that are going to come to us and say, I know that the books say and the guidelines say that I'm supposed to get chemotherapy. I will not get chemotherapy, or I really, really don't want to. And we bring up ctDNA in that setting really to say, okay, well, we're going to send this test off. If this test is positive and, you go over the data regarding the risk of recurrence with ctDNA positivity, and just say, listen, if this test comes back positive, will you accept chemotherapy? And their answer is yes. That's a clear-cut way to use ctDNA, keeping in mind what the patient's overall goals are. And then in regard to monitoring for response to adjuvant therapy, I have done this because if I do have a patient with stage 2 or stage 3 colon cancer that's receiving adjuvant therapy, I want to know if they're clearing their ctDNA because it tells me a lot about my surveillance plan, but also what I might have to offer them after the completion of adjuvant therapy. And Dr. Cohen showed you data showing that when patients sustainably clear their ctDNA, their outcomes are actually really good. But if they transiently clear or do not clear at all, their risk of recurrence is extraordinarily high. So I think that data is very, very helpful while you're treating with adjuvant therapy.
So, Stacey, we asked about whether people utilize ctDNA in the surveillance setting or localized therapy, whether patients have had adjuvant therapy or not. And here we see a lot of people are talking about doing that, interestingly. But then the question comes up, and we were talking about trials that look at this scenario if a patient turns positive, and most people would not treat, but surprisingly, 7 people would treat based on a positive ctDNA. I mean, I think about prostate cancer and PSA, and we treat PSA there because they totally know that predicts progression. Any thoughts about what do you do? First of all, do you use ctDNA in surveillance after adjuvant therapy, Stacey? And what do you do if it turns positive and there's no trial available?
Yeah, so I do longitudinal testing, and I try to put it in the context that Chris just referred to, that we're trying to think about it as one clinical factor that matters and that it does help us decide, frequency of imaging and whatnot. But let's say someone is ctDNA positive. I think I'm like some of the studies that were shown. I will often order reflex testing or order more frequent imaging, such as every 3 months. I typically would not start systemic therapy, as I don't think that necessarily helps the overall picture, because I want to know, where are they relapsing? Are they relapsing in an oligometastatic liver site? I might be able to get that person to NED, and that's what I want to try to do. And so for me, I would rather do more intense monitoring than start systemic therapy. Now, on the flip side, let's say that person's had 3 liver operations and it keeps coming back and their ctDNA is positive yet again. Sure, maybe in that scenario, I might end up starting systemic therapy. So I think as we look through these questions, I think there are scenarios that I can foresee. I could play pro and con of each side. But generally speaking, I prefer not to start systemic therapy based on ctDNA alone, because I want to understand, where is that person relapsing.
Arvind, what about this scenario of a patient who has metastatic disease, has gotten first-line therapy with FOLFOX-Bev and now is on 5-FU-Bev maintenance, and the patient wants to stop maintenance therapy? We asked whether people would utilize a ctDNA assay in that setting, and a third of the docs would. Any thoughts, Arvind?
Yeah, this is a really intriguing situation and interesting to see that split again. Seems like more providers would say no than yes. Uh, so I guess the question to ask would be, what are you looking for in the ctDNA assay to make that decision about stopping therapy? Is it ctDNA negative or is it lower than before? And then how does that relate to what you're seeing on the scans, right? I mean, I think that is probably more definitive as well. So I'll go out on a limb and say that I probably would not use a ctDNA assay, at least by itself, to make any decisions about stopping therapy. It would be driven by the clinical scenario and patients' their own wishes.
So again, I don't want to make too many analogies that don't apply, obviously, but the big trend now in metastatic prostate cancer is intermittent therapy. They treat the patient until the PSA goes away, and then they stop the therapy and they wait for it to come back. If it does come back, they retreat. So one final question, I'll come back to you, Stacey. This comes up all the time in oncology in general. People always ask, does ctDNA tie into the question of how long to use IO in a patient who's had a great response? Typically, people think about, MSI high disease, for example, or even in lung cancer, maximum of 2 years of therapy. We put out the scenario of a patient with MSI high disease who's getting IO and is in a CR, and after a year wants to discontinue therapy. And whether or not the assay would be used by our survey, we got complete unanimity, 10 versus 10, 50, exactly 50-50. I love that. So you go to one doc, you can stop at a year. The other doc, you have to go for another year. Well, anyhow, before we move on to the cases, I just want to kind of come back to you all and ask you what your thoughts are about this, what we ought to do about it.
Yeah, so what's kind of hidden in sometimes some of the stage 2 in particular questions is, this issue of the T4Bs and T4As. And I think that that granularity sometimes is needed to kind of know, is it truly low risk? Is it high risk? Having said that, I think this data is absolutely fascinating. It really proves that the data is compelling to some and not compelling to others. And I think that this is what happens when you have a lot of retrospective data, some early prospective data, and then some data like the celecoxib 80702 data, where nobody really knows, what to make out of that. It also tells you that we really need prospective studies and an earlier endpoint. We can't keep waiting for DFS events. And I think Dr. Dasari, Arvind made this great point about the fact that you're going to get looking at ctDNA clearance is a phenomenal early endpoint. We've seen great strides made in multiple myeloma. Looking at earlier endpoints, we know the FDA is really focused on this as well. And I think that we need to develop trials with early endpoints so that we can get some of this data out so that we can guide the decision making. Right now, it looks like half of us are convinced and half of us are not, depending on the clinical scenario.
Arvind?
What I would also recommend is perhaps going back and doing the survey again in a year and maybe in 2 years, and you get a sense of how trends are shifting over time.
Yeah, we lived through the whole Oncotype thing, and one of the things that happened in the early Oncotype, this happened over and over again. We used to do live polling at the meetings, and we would say, okay, would you do the assay? And half the people said no. And then we would go, well, suppose the surgeon sent the assay and it was positive, would you change what you do? And they all changed. Again, Stacey, any thoughts about this data?
Yeah, I mean, I think it's super interesting. I think the thing that would really kind of escalate it in my mind in terms of how compelling is to paint the clinical scenario and ask the question what they would do and then layer in the ctDNA, like, the young person that wants to stop their immunotherapy after a year. Let's find out how many people are just unwilling to hear that discussion, or the older person who wants to, skip therapy or whatever, because you may find, and I would expect that we all practice a little bit differently. And so I think you could really see the role of ctDNA if you could first parse out what our individual practice patterns are.
All right, let's get into some cases here. I think what we want to do here is have you briefly present the case and really turn to your colleagues and ask them a question. What would they do? Would they have done what you do? Any question about the case? So we'll start out with you, Chris, with your 41-year-old lady. I was joking with Chris yesterday. All these cases that you guys always present are always under the age of 50 because you see all the young patients. Even though I know there are a lot of them in general oncology practice, but I think you see a lot more. But anyhow, let's hear about this 41-year-old lady.
Yeah, they always seem to be young, right, when they come into our clinics, but we know that the average age still is around 67, 68. But this is a 41-year-old, and it just drills down to some of the survey questions. And so I guess we'll get to hear how you guys answered for this. But this is a very, very straightforward sigmoid adenocarcinoma that is low risk, T3 and 0, 0 out of 16 lymph nodes, positive for disease and microsatellite stable. And it's just a really easy question. If this patient showed up to your office tomorrow, what would you do in regards to ctDNA testing?
So, Stacey?
So I would talk with this patient about ctDNA testing. I think that my gut reaction is I would not give chemotherapy. I don't see any high-risk features. There's no disease. There's no microsatellite instability. So I think with all of that, as I sort of weigh the risks and benefits, I do not think that there's a strong role for adjuvant chemotherapy. On the other hand, I think that ctDNA positivity is very poorly prognostic. And so if that was present, then I would offer and recommend chemotherapy. And I typically would give an oxaliplatin doublet because at that point, I feel like I really am treating a high-risk patient. Yeah,
this is a real case. And as you might see, even the level is extraordinarily positive. Arvind, any thoughts in terms of what you might do next, given this pretty positive result?
Yeah, completely agree with what Stacey outlined. I would try to maximize adjuvant therapy for this patient, and I would try to push for 6 months of oxaliplatin-containing regimen, so option C.
Yeah, and what was remarkable about this patient was just that she was really positive, and there was no evidence of radiographic disease. We did offer her 6 months of FOLFOX chemotherapy, as you had mentioned, Arvind, and she actually cleared her ctDNA, and she remained sustained clearance. And that was back in 2022. She's still without evidence of disease. So, I mean, again, we don't have the prospective randomized data, but to me, that was just such a huge win.
I mean, you don't have to hear too many cases like this from my point of view to but maybe we need to present these to some of your colleagues. I don't know. Stacey, how about this 71-year-old lady?
Okay, well, I apparently picked much more complicated cases, because I had small font. So I have this lady, she's 71. She presented with a very large transverse colon mass. It was so large, it was exophytic. They thought it was maybe even invading into the duodenum. And her CEA was 98, but we didn't see any evidence of metastatic disease. So we decided to give her upfront chemotherapy, which is a little bit unusual, but they were actually concerned that she was otherwise going to need a Whipple at the same time. So she went ahead and got her chemotherapy, and they actually thought radiographically that maybe the transverse colon mass had gotten a bit bigger, and her CEA had gone up to 170. So they went to the OR. She had an extended right hemicolectomy, and she actually only had YPT3N1B disease. So thankfully, it was not invading into the duodenum at that time. It was a large, poorly differentiated adenocarcinoma with a partial response, 3 positive lymph nodes. And at that time, because she had some issues with getting molecular testing, it came back that it was an MSI high tumor with a BRAF mutation. And so now, of course, in this day and age, I would have given her neoadjuvant immunotherapy had I known what I know now. But at that time, we didn't have that data. And so when her MRD testing came back, because I was concerned she was chemo sort of refractory. We think that the mass looked like it had gotten bigger. Her CEA had gone up, and her ctDNA testing was positive at 0.07. At first, because of the lack of immunotherapy data at the time that this was done, we gave her a little bit more chemotherapy. Her ctDNA had gone up quantitatively, and I think she had started on immunotherapy, and at that time, that's when her CEA decreased. So because she was MRD positive, she's persistently ctDNA positive. We then decided to go ahead and put her on immunotherapy. She got 1 year of pembrolizumab. Her ctDNA briefly went up and then cleared. She's now 3 years out and is NED.
So Arvind, any thoughts about this case? And again, I think we talked about it briefly, but do we know much about ctDNA and shedding, MSI high versus MS stable? Any data right now looking at are the trials including these type of assays in their design?
So the ongoing trials, including Circulate North America, are using, at least here, are using Signatera as a tissue-informed assay. I know there are some European trials, such as Pegasus, that are using a tissue-agnostic Guardant Health, blood-only assays. So we will have data from both types of assays, but as Chris mentioned, there are different versions and iterations coming out. So by the time these data come out, very likely we'll have newer versions of these assays. So how do we future-proof? I don't think we have a clear answer other than banking samples for future comparison. With regards to this case, I think this is really compelling. And actually, MSI high ctDNA positive patients, there was a small trial that was done out of Memorial Sloan Kettering where patients who are MSI high, irrespective of primary site, were enrolled if they were ctDNA positive but negative on scans and treated with pembrolizumab. And the majority of those patients actually benefited and cleared their ctDNA and were radiographically negative as well. A small trial, but still kind of in line with what Stacey presented here, that these patients might benefit from immunotherapy, even if they're just ctDNA positive.
Just curious, Stacey, if you had known this patient, or today's patient presented today, and you knew the patient was MSI high from the beginning, how would you have managed the case?
So given how bulky that cancer was and the need for help with resectability, I would have treated her as per niche 2 and given 1 month of nivolumab and ipilimumab. I think if we still weren't sure about resectability, you could debate if you wanted to give more immunotherapy, but I've seen some very impressive responses to just the 1 month of immunotherapy. And so that was what I would do. I would give her 1 month of immunotherapy and then plan for resection thereafter.
And do you see any role for cell-free DNA? And if you had a complete response, maybe you had colonoscopy, or the thing, I mean, it seems pretty big, but completely going away, could you see any role for cell-free DNA?
I mean, if you want to make this even more controversial, we can talk about non-operative management for colon cancer, but I would say I would just be happy if hers cleared because I at least would be really concerned about the response that was necessary there.
I'm just sort of interested to hear Ipi-Nivo in the neoadjuvant setting. I mean, it makes sense, but it's just the first time I heard it. But have you any of you done that?
Oh, yeah.
I've had experience with single agent and double agent, and it's pretty wild. I even had one patient that had like a minor delay in getting to surgery, MSI high colon cancer. We gave like literally a dose of pembrolizumab, and there was a path CR and what we considered to be a fairly bulky tumor up front. It's one of the wilder things that you can see in clinical practice.
All right, Arvind, let's hear about your 46-year-old patient.
Yeah, so in line with early onset colorectal cancer, 46-year-old gentleman, metastatic sigmoid colon cancer, actually underwent resection of both the primary, that was T3N2, and an isolated liver met. They're both resected before the patient came to see us, and we recommended 6 months of adjuvant chemotherapy that the patient finished. And about 15 months or so after completion of adjuvant chemotherapy, was noted to have a positive MRD test. And we did extensive testing at that time, including imaging, scope, that were all negative. so truly MRD positive. And after an extensive discussion, the patient actually elected to enroll onto an ongoing clinical trial here at our institution that was evaluating a novel immunotherapy agent for patients exactly like this, MRD positive. Only without any radiographic evidence of recurrence. The patient was on the trial for about 4 to 6 months. So as you can see here from the initial rise in ctDNA, it continued to increase even while on the trial, even though scans were negative. After about 5 to 6 months on the trial, the patient actually elected to come off of study. So believe it or not, the end of study CT actually showed a possible hazy lesion in the liver. So this was followed up with an MRI with EOVIS that confirmed it. And we discussed with our hepatobiliary surgeons and interventional radiologists. And the recommendation was to proceed with ablation, which the patient had of this lesion. And subsequently, the MRD test turned negative. And the patient continues to be on surveillance.
Any questions for your colleagues?
I guess the one question for both Stacey and Chris would be, at the time when the patient turned ctDNA positive, but there's nothing on imaging, I mean, what would you have done? Or even before we get to what would you have done, what sort of workup do you typically do for these patients in terms of what kind of imaging? Do you only do CT, or do you do a PET scan as well? Do you scope these patients? Maybe start with that. What workup would you do?
Stacey?
I would say I get most worried about liver recurrence just since it is such a high shedding site. I used to agonize, should I get an MR abdomen? Should I get a PET? And now with the onset of PET MR, you can have it all. So I would say that sometimes is a test that I will order just to kind of maybe try to address all answers. Certainly if this was a patient who had previous liver metastasis, I might maybe focus more in on that, or previous lung metastasis. Maybe I'm more worried about looking for a site of prior metastatic disease. But without the opportunity for a trial, I would probably get a PET MR. If it was negative, as many times they still might be, I would follow with imaging every 3 months and decide if I want to do a CT cap or maybe I want to do a CT chest and MR abdomen pelvis for my ongoing monitoring.
How about colonoscopy?
If they are due for one, sure, but I haven't found a lot of instances where that has happened, though I can think of one case where they did have a local recurrence that was found endoscopically and had no metastatic disease, but I would say that's definitely in the minority.
Yeah, so that was actually my patient. Yeah, so I did same thing. I mean, every 3 months you're going to get a CT scan. I love the idea sometimes of a PET MR and just getting all that information kind of all at once. PET scans obviously drive us crazy, and there's a reason why they aren't necessarily on the surveillance guidelines, right? But we do worry about false positives, but here you're just casting a wide net. But I did have a patient that had a persistently positive ctDNA and eventually did get a colonoscopy. And sure enough, there was a local recurrence at the anastomosis. And we resected that, and then the ctDNA cleared. So I do like the idea of if you have this imaging and there's just nothing that you see, I think it's reasonable to get a colonoscopy.
So, Arvind, before we go on to the next case, I'm just kind of curious. I note that this patient was treated with ablation for this isolated hepatic met. When do you use ablation versus surgery?
Yeah, usually kind of discuss in a multidisciplinary setting about kind of what the best approach is. It depends on the patient comorbidities, the patient's overall health of the liver, and also, importantly, the size and location of the tumor. This patient had a fairly peripheral lesion and was not very large because we were scanning the patient so often. I think it was less than 2 centimeters. So based on all those factors, decisions are made. For this patient, is overall healthy, could have tolerated another surgery, and even though he got 6 months of oxaliplatin, liver was still looking good. But just the fact that it was a small lesion and kind of somewhat in the periphery, went with ablation.
All right, Chris, 51-year-old man. This is like a rapid walking down the hall making rounds type thing.
Yeah, again, keeping the cases a little bit more straightforward. We talked a little bit about this, and again, this patient is a little bit more age appropriate for colorectal cancer, but basically, just like the stage 2 case that I presented before, this is low risk, just 1 out of 16 lymph nodes positive. So low risk stage 3 sigmoid colon adenocarcinoma. Patients from Boulder, represents a little bit of a different patient population, does not want any chemotherapy, says, I understand the numbers, I don't want to receive chemotherapy, but wants to opt for ctDNA testing. And this, of course, the ctDNA testing a couple weeks after surgery is indeed negative. And so my question to my colleagues, and we can start with you, Arvind, is that, right, for this patient, we know certainly what the guidelines tell us, but what would you do in this situation? And this is just real life, right? This is what we see. Patients sometimes come in and they have ideas about their therapy.
Yeah, I mean, I think this is a situation where the decisions will be driven largely by what the patient wants. If the ctDNA were positive, I would really kind of strongly recommended adjuvant chemotherapy here. If the patient does not want to do adjuvant chemotherapy, in spite of counseling about what the guidelines say, then the next thing I would ask is, would you be willing to do, say, an attenuated, single agent therapy? And if they say no to that, then observation with serial monitoring. What we don't know is the efficacy of adjuvant chemotherapy if they turn ctDNA positive, and whether doing adjuvant chemotherapy at that time would still be with curative intent. That is what Circulate North America, as you know, is testing. But bottom line, after a lot of counseling, if the patient is comfortable, observation.
Yeah. The answer always for this is, to enroll to Circulate. But Stacey, anything else to add?
No, I think this just keeps in mind that we universally recommend adjuvant therapy in stage 3. We also know that the vast majority of patients are not getting benefit from their adjuvant chemotherapy, either because they were going to recur anyway or they were cured by surgery. And that really that the percentage of people that are receiving benefit from chemotherapy is much smaller than I think we'd like to admit. And so I think patients' viewpoints really matter. And as somebody in the Pacific Northwest, I can relate to the patient who does not want to get chemotherapy or has opinions about it. And so I think ctDNA can sometimes be a compelling factor to say we're not treating you with sort of this blanket statement. But if I have any sign of detectability of disease, whether, that could be a scan, that could be a blood test, but, a ctDNA being one example of that would you then consider it in that scenario? Yep. Or would we use a ctDNA negative test to feel more comfortable with de-escalating, like Arvind had talked about? And so I absolutely love the Circulate trial, and I think that is the better way to approach this question, which is to do it systematically. But for that person sitting in front of you, whatever they want goes, because it is, I tell everyone, it's a good insurance policy. It is, we don't know if you're going to benefit from it.
So I was mentioning to Chris that we've done a lot of posters over the years, but we actually did one oral presentation at an ASCO GI meeting, actually in Orlando. So you can tell how long ago. I don't remember. It was more than 10 years before they went to San Francisco. I completely messed up, incidentally, doing the presentation. But anyhow, what we did was we tried to reproduce a study that was done in breast cancer patients where they said, okay, you have this amount of benefit. Would you want adjuvant chemotherapy? And that this sort of idea came out that there were a lot of patients who would go through chemo for very minimal benefit. So we got a bunch of people who'd actually gotten adjuvant chemotherapy. We asked the patients, we gave them these charts with 100 people, and we gave them the numbers. Here's the risk with treatment, here's without, would you want benefit? And incidentally, we found 30% of those people would be treated to reduce the risk of recurrence by 1%, and 10% of the people would not be treated even for an absolute difference of 10%. So a lot of heterogeneity there. And also, interestingly, because people used to say, well, the breast stuff is because women are more proactive, we saw the same responses in men and women. So I want to kind of try that experiment a little bit here. So Arvind, let's take this case, one positive node. The patient says, what's my risk of recurrence if I get the chemo? What's my risk without it? Now you've got a negative MRD, and I'm going to ask the patient asks you the same numbers. Now you know my MRD is negative. What's the risk of recurrence with or without treatment?
Yeah, I mean, this actually brings up something that I've been kind of discussing and wanting to do is, back in the day, we had adjuvant online that would really spit out the exact numbers. So we need to do that for ctDNA information as well. That'll really provide those numbers. I'm not sure if I can give exact risk of recurrence numbers, but as Chris and Stacey discussed, even in stage 3 colon cancer patients, about 40 to 50%, if not more, are cured by surgery alone and never need surgery, never need adjuvant chemotherapy. And of the rest who may develop a recurrence, that risk of recurrence is correlates fairly well with the T stage and the end stage. So this patient had fairly early T stage and end stage. So I would say their risk of recurrence overall is probably on the lower side of stage 3 colon cancer patients. And what we also know is that the rough benchmark for benefit from adjuvant chemotherapy is that it reduces the relative risk of recurrence by about a quarter, about 25% or so. So in this patient whose initial absolute risk of recurrence is low, and thereby their benefit from adjuvant chemotherapy would also be much lower. Not sure if I can come up with exact numbers. Stacey, Chris, what are your thoughts?
Well, I like to use an analysis from the IDEA trial where they actually broke out what they thought the absolute risk reduction of each surgery and chemotherapy was by T stage and end stage. And so that's something I will look at as sort of my mock version of adjuvant online, since we no longer have that for stage 3 patients. And so I would probably quote, an absolute risk reduction of 10 to 15% for most patients for chemotherapy, maybe on the lower end for, an early, lower stage, T stage and lower end stage. And then I like to tell patients that what we have observed is that the recurrence risk in ctDNA negative patients is about 5%. So the assumption is that, I think we're looking at single digits, most likely, but we also know that if that affects that one person, that can be, life-changing. So I still recommend chemotherapy for stage 3, even if I knew someone's ctDNA results and they're not on a trial, but I try to at least use that information to counsel them what we might anticipate. Chris, what about you?
Before you comment, I just want to say, Arvind, I'm so glad you brought up adjuvant online, because we used to work with Peter Rath, that's where we got this whole idea. Mm-hmm. But before Chris, before you answer, and you can maybe even refer to this patient, to me, there's a pretty big difference by saying, well, we're not exactly sure. Remember, maybe the patient's a medical oncologist. They can totally understand this. Maybe you can say, look, we really are not sure of the numbers, but we think there's maybe a 10% or 15% chance you're going to avoid recurrence by getting chemo, which is what you just said. If you believe that the risk with an MRD negative is 5%, it's not going to be 5%. It's going to be less than 5%. That's a big difference. If you think it's more like 3% versus 10 to 15, at least to some people, I think it would be a big difference. So I guess my question is, Chris, you guys have seen, it's more like an on-off thing, but in breast cancer, they give the numbers. And I think if you start looking at the numbers, maybe it looks a little different. I don't know. Any thoughts about that, Chris?
Yeah, so this is... I love this, and the idea of ctDNA adjuvant online I mean, Arvind, it's such a great idea. So I think that those numbers that you both brought up are really spot on. I think that there are probably two things that we need to kind of keep in mind. Number one is certainly informed decision making. And when you think about if the recurrence risk is in the single digits, your number needed to treat to prevent one recurrence is extraordinarily high. Whereas we know that the number needed to harm with chemotherapy is also like actually quite lower when you kind of compare the data side by side. And so it's really, there's a bit of a dichotomy in terms of how breast oncologists and GI oncologists actually interpret data. A breast oncologist may look at a survival benefit of 2 to 3% and push forward with a super aggressive therapy, whereas I think traditionally in the GI oncology field, we might look at that and we might assume that our patients would say, I'm not doing that for 1 to 2% benefit. And so this really comes down to the second part of that, and that is just the informed patient decision making, where so I think I love this idea of giving somebody the number saying, okay, you're low risk stage 3, your ctDNA and the MRD window is negative. That puts your risk at 10% or less. Does that inform or help you make a decision in terms of whether you want chemotherapy? The guidelines say we should give it, okay? But the patients may hear those numbers, and some patients may say, give it to me. I'll take every percentage point I can get. And then there are other patients that when they hear the numbers, they will say, no way, especially if they're aware of the side effects of the chemotherapy, if they've already received some or not.
And incidentally, you talked about investigators in breast, investigators in GI. There's another group out there, which is the general oncologists that's seen both of this. Mm-hmm. So they're hearing the breast story and they're hearing your story. And incidentally, I was just flashing. You probably don't even know what this is. And people are listening to this. I'm holding up a book for those of you who are listening. This is Adjuvant Therapy of Cancer 6, a book. So there used to be a actual meeting. I think it was in Arizona. Sid Salmon would run it, and people would write up their papers ahead of time, and they would publish it as a book a few months later. It was multidisciplinary approach to adjuvant therapy. It wasn't just breast. It's everybody presented what was going on in breast. I don't even remember. It was like a long time ago, obviously, before we were even using computers. But again, there's this long history of numeracy that came out of breast cancer, but it doesn't, like lung, they don't get into it at all either. But the general oncologists see this in breast and they wonder why don't you give the numbers to the patients? But anyhow, it's just a thought. All right, now we're really good. 31-year-old man, Stacey.
I had a 31-year-old man who presented with pain and bleeding. He was found to have a descending colon mass, no metastatic disease. So he underwent upfront surgery, revealing T4A and 0 disease. It was poorly differentiated, mucinous adenocarcinoma, had some other high-risk features, but not any lymph nodes, and was MSS. And he did get ctDNA testing and was MRD negative. And so based on him being high risk, T4, as we kind of had talked about before, I still recommended adjuvant chemotherapy. He got 3 months of Capox. His ctDNA was trended for 2 years, was negative for all draws. He's now 5 years from surgery and NED. And so I thought that this was just a good example of highlighting the fact that in this patient that clinically we labeled as it being extremely high risk for recurrence, was that really the factor that we should have been focused on, and the one that told us to give him chemotherapy, or should we have been focused on the fact that he was ctDNA negative? Because we have this tendency to think that young people, we should probably treat them more aggressively because we know that they often have really aggressive cancers, and yet here's a 31-year-old man who remains NED.
And again, Arvind, I think our survey says that a lot of people would have used the chemotherapy in this situation. Would you have?
Yeah, I think just given the fact that this is a T4A tumor and also that this is a poorly differentiated mucinous histology as well, would make me nervous not to do adjuvant chemotherapy, even though the ctDNA assay was negative. So I think I probably would have done the same.
Arvind, do you want to talk about your 51-year-old patient?
Sure. So this is a 51-year-old a patient with T3N1 sigmoid colon cancer, underwent resection and then came to see us. It turned out that the histology was actually a high-grade neuroendocrine carcinoma. And so the patient was started on adjuvant therapy with a platinum etoposide regimen and actually progressed while on adjuvant therapy within a few months. And then the patient was started on second-line FOLFIRINOX, given the rapid progression, and blew through that as well. And these were the images, widely metastatic disease, including peritoneal disease and malignant ascites as well. So the patient actually had a very high TMB related to polymerase epsilon mutation and was actually initiated on immune checkpoint inhibitors, actually Ipi-Nivo. And had a dramatic response with apparent near complete response on the scans. As you can see, these are the images after the immune checkpoint inhibition therapy. As to be expected, she did develop fairly significant IO toxicities, including hypothyroidism, adrenal insufficiency, and also some arthritis as well. But she was really, really nervous about stopping therapy, given how extensive the disease was when she started immune checkpoint inhibition. So we did everything we could, including extensive imaging, including MRIs and FDG PETs and endoscopies. Everything came back negative. And then after an extensive discussion, what we decided was that, look, we're going to check ctDNA as well. And if that comes back negative, then maybe we can stop immunotherapy. So we did the first one, came back negative, and she said, well, just one more, and then we can stop. And so the second one came back negative as well. And after that, she was more comfortable stopping immunotherapy and just continuing surveillance with imaging.
So before I ask Stacey to comment, just kind of curious, Arvind, are you I don't know how often you see Poli. I've seen very few cases presented to me. But if you saw her again, or you have next Poli, do you generally use Ipi-Nivo or just single agent IO? I thought these were like exquisitely sensitive to IO.
Yeah, I think a single agent checkpoint inhibitor would have been perfectly reasonable. The only reason we went with that was, the way the things looked at that time, given the rapid progression and how symptomatic she was, we needed, wouldn't have had a second chance, so wanted to give it our best shot.
Stacey, any comments on the case? Have you seen any patients with Poli?
I have. It's about 1%, and I think that's reflected in my clinical practice. I've seen a couple, but they are exquisitely sensitive to immunotherapy. And I think this here is a good example of what I had said before, that ctDNA can increase your confidence in a decision you were starting to think about anyway. So here you've got a patient with high-risk disease who's very hesitant. And so I think that was a really helpful way of sort of hopefully trying to ensure a good outcome. I think it's great.
All right, let's finish out with Chris's 63-year-old man.
Yeah, so a little more complex than my other two cases. Because this is a patient with stage 4 colon cancer, initially had stage 3 and underwent right hemicolectomy in 2022 and received chemotherapy. We talked about that. Normally, this patient would have gotten 3 months, given that it's low-risk disease. This patient ended up getting 6 months total of FOLFOX at an outside institution. But interestingly, and Arvind had shown great data on the low positivity rate that we see in patients that are serially negative when you get out to like 18, 24 months. And this is a really unusual situation where somebody, over 2 years out from their original resection actually ended up having a positive Signatera. So that was in June of this year. And with the positive ctDNA, normally we would be getting annual CT scans. This patient actually got a CT scan and a PET scan and certainly right there. You see the right upper lobe lung nodule with moderate activity, suspicious for malignancy. And so this is a situation where ctDNA told us to do something that we otherwise would have just waited another 6 months to get. So the patient underwent a right robotic upper lobectomy with a medial sternal lymph node dissection. And so the patient did get the lobectomy, had colon adenocarcinoma in the lung, but actually had a positive lymph node as well. And you can see that the post-operative 1 month later Signatera was actually, it went from 0.12 to 0.09, so it's persistently positive. And so, my question to my colleagues here, we debate, particularly after patient has received prior adjuvant therapy, and this was all the way back in 2023, what the benefit of quote unquote adjuvant chemotherapy is in this setting. And then on top of that, we have a ctDNA that, unlike Arvind's patient, didn't clear. And so the question, and I'll throw it to maybe you first, Stacey, what would you do in this situation, assuming that all the postoperative imaging was negative, which it was?
Oh gosh, it's so tricky. I think that stage 4 adjuvant therapy is controversial at best, whether or not to give chemotherapy. When someone is negative, again, I feel better about not giving it. When they're positive, I do tend to give it. I think the issue can be is if you have those indeterminate findings, that may be one of those situations where you may intentionally not give chemotherapy if you think that their scans are suggesting that you want to see if something develops into another site that you could potentially resect. But I would say I kind of go back and forth based on the other clinical factors about whether or not to give or give. But when I do, I typically give 3 months of an oxaliplatin doublet.
Arvind, any final comments on this case? It's interesting, too, that this patient didn't just have an oligomet in the lung. They also had a regional node when the patient was operated on, which is a little bit more concerning. Any thoughts about this case, Arvind?
Yeah, I think this is a situation, if you'd posed it to the survey group, instead of a 2-way split, you'd probably get a 3 or a 4-way split. Right. But I completely agree with Stacey in that kind of no right or wrong, but doing some oxaliplatin-based adjuvant chemotherapy without causing excessive toxicities would be very reasonable.
All right. Well, I can't thank you all enough. It's been a great experience here, sitting here listening to you. I can't wait to get this program out and see what people think about it. This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. The use of agents and treatments that are not approved may be discussed in the program, so check out package inserts for more information. Special thanks to our faculty, and thank you for listening. This is Dr. Neil Love for Striving for Consensus.